So blood cancers are of three types: leukemias, lymphomas, and multiple myeloma. Leukemias basically are two types: chronic leukemias and acute leukemias. Acute leukemias, we know them as AML and ALL, whereas chronic leukemias, few or CLL and CML. Whereas coming to lymphoma, this is a cancer which arises from the lymph nodes. So lymph nodes basically have white cells in them. And these are two types of lymphoma. One is non-Hodgkin's lymphoma and a Hodgkin's lymphoma. Coming to the myeloma, myeloma is a type of blood cancer which arises from the marrow, from a plasma cell. So plasma cell is normally component of a marrow, it accounts for less than 5% of all the marrow elements. So when a plasma cell turns neoplastic, it increases in number drastically and occupies the marrow and suppresses the normal marrow elements, leading to multiple myeloma. So coming to the symptoms of myeloma, as I told you, the plasma cell is the neoplastic cell here, and when it increases in number, it tends to suppress the marrow and normal elements, thereby producing anemia. So anemia is one of the most important symptom in these patients. So anemia, the range we see from 6 grams to 8 grams, even 10 grams in these patients. Other than anemia, these plasma cells tend to erode the surrounding bone in the marrow, leading to lytic lesions which can produce bone pains. So bony pains is the second important symptom in these patients. The most common set of bony pains being lumbar spine. So but still they can have pain in any part of the body. And the third symptom is, once this plasma cells starts eroding the bone, they produce a lot of calcium, leading to hypercalcemia. The patient can also present with symptoms of hypercalcemia. Hypercalcemic few important symptoms are like mood changes, neurological changes, constipation, even some cases seizures. So other than these three symptoms, these plasma cells can secrete a toxic protein which release into the blood and they get deposited in the kidneys, leading to renal failure. So once the kidneys are affected, the patients can have pedal edema, periorbital puffiness, and generalized swelling, anasarca, and decreased urine output. These are some of the symptoms with patients having with renal failure. Again, renal involvement is also a very important aspect of multiple myeloma. Other than these three symptoms, patients can present with the constitutional symptoms. So what are constitutional symptoms? Cancer per se has few symptoms like weight loss, low grade fevers, and night sweats. So these can also be the few symptoms. So different patients come with various combination of these symptoms. So once the patients come with these symptoms, how do we diagnose multiple myeloma? So we run certain blood tests and do certain imaging here. So in blood we do complete hemogram to look for anemia, and we do a liver function test where we get a total protein. Usually these patients have an elevated total protein which reflects the M band in these patients, followed by the renal function test to check whether the renal system is involved or not. And we also check for calcium levels. Other than this, immunofixation electrophoresis is the test which helps in diagnosing the myeloma. Basically this test measures the M band in these patients. M band is a monoclonal band which is secreted from the neoplastic plasma cells. And other than these tests, bone marrow is very important test here. Marrow is done to check the percentage of plasma cells here. In myeloma, we see more than 10% of clonal plasma cells, up to 60%, even sometimes 80-90% in these patients. So these are the few tests which we do in multiple myeloma. So after diagnosis, how do we treat these patients? Once we diagnose multiple myeloma, we always do tests to diagnose the disease, and simultaneously we try to stage the disease. So what do you mean by staging here? Staging in blood cancers differs from staging in solid organ malignancies. Means the cancers of our body like lungs, breast, different. So here mainly blood cancers are staged mainly to differentiate low risk disease from high risk. So what is low risk, what is high risk? Low risk diseases are the ones which are a favorable clinical genetic profile or favorable clinical profile. These patients tend to do well, respond well, have a longer survival. And whereas high risk patients, they tend to respond less to the standard chemotherapy or standard treatment, and they have a shorter survival span. That's why the modification of regimens depends on the risk status of these patients. So other than diagnostic tests, we also do certain genetic tests to know the risk status of these patients. So once we classify them into low risk and high risk, usually we then go for chemotherapy. And usually these patients, there are different kinds of chemotherapy. So we have drugs used as a chemotherapy, we have immunotherapy, and we have targeted therapy here. Usually standard risk patients, we start with triple drug regimen here, and we give it for in a cycles, say 4 cycles. And again we classify patients here based on fitness, whether is a fit patient or an unfit patient. Usually fit patients, they go with 4 cycles chemotherapy followed by stem cell transplantation. So stem cell transplantation plays a crucial role in these patients in providing the deeper remissions. So those who receive 4 cycles followed by stem cell transplant tend to develop a very good responses and will have a very longer survival rates. In unfit patients where we don't do stem cell transplantation but we continue chemotherapy and to 8 cycles, and then we tend to keep them on some kind of maintenance therapy. So basically transplant plays a crucial role here in fit patients. So we follow up them closely. Usually those who respond very well to chemotherapy or to treatment, survival rate exceeds 70% after 5 years.